We're going to talk about pain management in dysautonomia. Disclaimers, number one, I work for the federal government. Everything presented here does not reflect the views of the federal government or any of its branches. Additionally, we are going to be talking about off-label uses of medications to treat pain. So we're going to talk about the problem of pain in dysautonomia. And we're going to talk about some mechanisms by which those pain syndromes can occur. We're going to talk about medicines that we use to treat pain in dysautonomia. But the take-home message that I want you to walk away with is we treat pain in dysautonomia at this point in the year 2017 like we treat other pain conditions. However, there are particular comorbidities in dysautonomia that we need to be aware of when choosing our approaches to treating the pain. So we're going to talk about those unique comorbidities and the side effects that we have to particularly consider when choosing pharmacologic therapies. So pain's a big problem. I'm talking to you all as a group generally of clinicians, and I recognize that you recognize that pain is a problem in the United States. So about 1 out of 5 adults in the United States has chronic pain. About 10% of all adults have neuropathic pain, and the numbers range, but most studies come up with a number somewhere around 10%. Those numbers are augmented in our clinic populations, so it's something that affects a lot of the patients that we see. Well, what about the dysautonomia population specifically? The quick answer is we don't have a good handle on this. Last year at this conference, Dr. Raj presented these numbers from the Big Pot survey that about 40% of patients who self-identify as having been diagnosed with POTS report migraine. You can see the numbers up there for IBS, fibromyalgia, and endometriosis. And this is the way I conceptualize pain in dysautonomia. One thing you've probably appreciated this morning that we saw in yesterday's pre-meeting meeting is there are a lot of Venn diagrams. There is a lot of overlap. If I were smarter in PowerPoint, I would probably make these circles overlap more than they do, because I think these things have more overlap than less overlap. But this is the way I generally approach pain diagnosis and treatment in my autonomic disorders clinic. There's that small fiber neuropathy type pain, really a peripheral nerve pain, pain related to central mechanisms, specifically central sensitization, and then the pain related to musculoskeletal disorders, specifically joint hypermobility. In just a few minutes, Dr. Francomano is going to talk to us about joint hypermobility and Ehlers-Danlos specifically. So let's start with those peripheral mechanisms of pain. Now, one thing that I don't have up here is migraine. So we'll touch base. We'll touch on that at the end, but that could be a whole other lecture and more in itself. So, peripheral mechanisms of pain. This morning you saw pictures shared by both Dr. Sandroni and Dr. Vernino of electron microscopy showing the different nerve fiber types. We have our large, heavily myelinated nerves that are responsible for proprioception, vibration sense, motor function. And then are smaller diameter, lightly myelinated, and unmyelinated nerves that are responsible for pain, temperature sensation, itch sensation. And it's these sensory nerves that are very similar in structure to our autonomic nerves. So the autonomic nerves and the pain temperature sensing nerves are these small diameter, lightly myelinated, and unmyelinated nerves that share a lot of structural homology and are often affected together. But not all pain related to small fiber nerves is necessarily what we conceptualize as neuropathic pain. And the at least in my mind, a lot of the evidence for this comes by work that was started by Anne-Louise Oaklander's group at Mass General, when they took a group of patients diagnosed with fibromyalgia, did skin biopsies, and looked at epidermal nerve fiber density. As they looked at epidermal nerve fiber density in patients diagnosed with fibromyalgia, so this was not any patient group that was selected for having neuropathy. They just said, hey, this group of fibromyalgia patients, how many of them have evidence of small fiber neuropathy? They found that about 30% of them did. That's a pretty significant number. Very similar study done by Maria Giannocotto's group in Bologna basically did the same thing, looking at fibromyalgia patients and rates of small fiber neuropathy, and again came up with numbers right around 30%. And then it was done in Germany, and again the numbers were right around 30%. I don't remember the exact numbers, but all of them had very consistent numbers that about 1 out of 3 patients that met diagnostic criteria for fibromyalgia had evidence of a small fiber neuropathy. So that, in my mind, makes me say, okay, I need to be thinking not just about that classic burning distal predominant neuropathic pain, but that other pain syndromes can be related to small fiber neuropathies. And again, there's that overlap between the small fiber sensory involvement and the small fiber autonomic involvement. Another interesting condition that we can learn a lot from are mutations in the SCN9A gene. You saw a picture this morning of a patient's feet with erythromelalgia. And hereditary erythromelalgia is caused by a mutation in the SCN9A gene, which codes for one of the subunits of the voltage-gated sodium channel. And different mutations in the SCN9A gene can do different things to the voltage-gated sodium channel. Ramp up its activity, decrease its activity, but what ends up happening is various combinations of either sensory dysfunction, mainly with increased pain, and or autonomic dysfunction. So you can see three of the genetic conditions listed there that are caused by different SCN9A mutations. Not something that we diagnose common clinically, but in terms of concepts and mechanisms, I think illustrative to us to learn from. So we know that the sodium channel is important in neuropathic pain syndromes. One thing that has been shown to happen in neuropathic pain is upregulation of transient receptor potential channels. So these voltage-gated channels that are activated by different analogs, so a common one being the vanilloid receptor, so transient receptor potential vanilloid. So this TRPV1 protein is often upregulated, it has been shown to be upregulated in neurons in people with neuropathic pain, including focal neuropathic pain. So this receptor is activated by capsaicin. So this is your burny, icy, hot pain receptor, is how the non-pain guy thinks of it. Other things happen in nerves that are injured and demonstrating increased neuropathic pain, including upregulation of the calcium channel. And this happens closer to the synapse, where you get a presynaptic upregulation of the calcium channel, greater calcium influx at the presynaptic site, and therefore greater synaptic signaling, and therefore increased pain. So other mechanisms to think about, so we talked about the sodium channel mutations, but it's also been shown that sodium channels are upregulated in neuropathic pain. And of the mechanisms, at least in terms of therapeutics in 2017, in terms of mechanisms, probably the most important of the three on this slide is the sodium channel upregulation. But there is downregulation of potassium channels in the dorsal root ganglia, and there's increased substance P release in neurons that are, at least in neurons in areas affected by neuropathic pain. So we talked about voltage-gated sodium channels, we talked about transient receptor potential channels, we talked about calcium channels. Interesting thing to think about, at least in some of our patients, and more of the achy pain that they describe, and something that probably merits further investigation. This group from Washington University looked at the innervation of small blood vessels within the muscle in small fiber neuropathies, and showed that there was a loss of nervous vascular control, or at least there was a loss of innervation to the small muscles, loss of innervation to the vessels in the small muscles. And their conclusions based on that were that there may be some focal ischemia in muscles due to dysregulation of blood flow on a microvascular vascular level. I think it's very interesting when we look at the types of pain that our patients with dysautonomia describe. Definitely something that needs to be looked at further. So, moving from peripheral mechanisms to central mechanisms of pain, and I think about the balance between gain, that is, how much pain signaling is going to be going upstream through the spinal cord into the brain and coming to the level of conscious awareness, and descending inhibitory pain pathways. So there is evidence based on functional MRI studies that patients with chronic pain do have an increased signaling between certain areas of the brain, making people more aware of pain for a given stimulus threshold. Probably this applies to other sensory modalities, not just interoceptive or tactile sensory modalities. But when our patients with dysautonomia complain about the intensity of lights, the intensity of sounds, that things just being turned up too much for them, that internal buzz, maybe that is due to an abnormality of central sensory gain. We do know that this is related to increased glutamatergic activity, and it can be blocked by NMDA receptor antagonists, things that keep glutamate from binding to the NMDA receptor and continuing that excitatory signaling. Patients and animal models with chronic pain display decreased serotonergic and noradrenergic inhibitory activity in the spinal cord. Interestingly, at least in fibromyalgia patients, there is not any decreased endogenous opioid release. And so keep that in mind, that opioid release in the central nervous system of people with fibromyalgia is not decreased, but serotonergic and noradrenergic pathways are decreased. And so we see this alteration where there's decreased inhibition and increased gain, leading to increased sensory signaling. And central and peripheral mechanisms can and do coexist. And that's what we have to keep in mind when we're addressing a specific patient in our clinic. So, how do we go about treating pain? Like I mentioned at the beginning, the approaches that we have in treating pain in our patients with dysautonomia are really the same as the approaches we have in our general clinic population. So we have pharmacologic treatments. So we talked about calcium channel upregulation. Well, how can we address that? Well, we can use gabapentin or pregabalin. We talked about sodium channel upregulation, either upregulation of the channel itself on the neuron membrane or increased signaling of the channel. How can we address that? We can use agents that are active on the sodium channel, like carbamazepine or oxcarbazepine. We talked about the changes in serotonergic and noradrenergic inhibitory pathways. Well, how can we affect those? We can pick agents that act on serotonergic pathways. We can pick agents like the SNRIs that act on both serotonergic and noradrenergic pathways. We talked about altered transient receptor potential activities. Well, how can we address that? We can use capsaicin. Just like the rest of the patients that we see. So how are we going to choose? Well, it really comes down to the patient that's in front of us, what he or she is dealing with in terms of other symptoms, other medications he or she is on. For example, if someone has a big problem with constipation and dry mouth, I'm probably not going to want to choose a tricyclic with its prominent anticholinergic activities. That said, if someone has a lot of problem with insomnia, a tricyclic might be a very good choice for that person. If someone has a problem with weight gain, I might shy away a little bit more from the gabapentinoids. If I want someone to gain weight, I might choose that accordingly. Few things that are still under investigation in treatment of pain. These are at least the NMDA receptor antagonists. This is something that I've not used in clinic, but my patients that have more severe pain syndromes who are seeing pain specialists, some have benefited from ketamine infusions. Again, not something that I feel comfortable doing in my clinic, but definitely in conjunction with our pain management specialists. Unfortunately, it's a very short-lived effect. Perhaps something that may prove useful in the future, but I think as of 2017, we still need more data to support is the use of dextromethorphan, again, for blocking that excitatory glutamatergic signaling in the central nervous system. So we talked about endogenous opioid release being normal, at least in fibromyalgia patients. Well, there may be a role there for using low-dose naltrexone to allow increased signaling of what has been termed conditioned pain modulation, where blocking endogenous opioid release results in greater endorphin release to modulate pain. I think not something that's been explored super well, and definitely not in the autonomic disorders population, but this is the use of low-dose naltrexone is definitely something that my patients bring up to me in clinic, not infrequently, and something that some of my patients have derived benefit from. If you were to say, okay, Glenn, but what do you do when they ask you about the possible anti-inflammatory mechanisms of low-dose naltrexone? I would say I don't think we have enough data to go down a pathway of using low-dose naltrexone for anti-inflammatory purposes, at least as of 2017. But if it's something that we think may help patients' pain, it may be worth a try depending on your availability of compounding pharmacies and expense to us, patients, our systems generally. So what about non-pharmacologic treatments? We've heard about these already this morning, and I think it's worth harping on these even more because in the end, these will probably do more for the average patient than the pharmacologic modalities that we have. So sleep and pain. Dr. Raj mentioned how he gets destroyed when he's sleep deprived, and I think most of us in our professions have been there. And I know I'm not a headache person until after I'm on call, and then I suddenly become a headache person. Sleep leads to pain, and pain makes it hard to sleep. If I had any specific magical tricks for interrupting this cycle, I would definitely share them with you. I don't have any magic tricks, but working on that cycle, piece by piece, bit by bit, I think does make a very big difference. Exercise. We know that exercise increases those central descending pain inhibitory pathways. So you exercise, you're going to have increased endogenous release of endorphins. You exercise, you're going to have increased serotonergic and descending noradrenergic signaling within the central nervous system. Exercise helps pain. We've already talked today about the challenge that is in patients with dysautonomia who have exercise intolerance. So what the conversation that I typically have with my patients is, do something. Start somewhere. Just do something active every day. I don't care what it is. And I have the conversation with them about recumbent exercises, swimming, rowing machines, the things that are often helpful. But I tell them, just do something that you enjoy. A lot of my patients are still in the situation where they tolerate standing up. So I say, look, whatever you want to do. One patient whose dad wanted him to be the football star. A big kid, physically looked like he could have been a football star, but had a lot of exercise intolerance, pre-syncope, especially when football season came. So he and his mom and I had a very candid conversation about, do what you want to do. If it's playing ping pong and that's your thing, go out and play ping pong. Don't feel like you need to play football. And actually, however that conversation went down, it was actually very liberating to him. And he was able to transition his activities to doing other things that he felt better doing. So in terms of exercise, do something that moves your body and makes you happy. I don't know how many of your patients have had TENS units for one condition or another, and then they keep it around their house and just put it wherever it hurts. I see a lot of heads going, yep, my patients do that. Mine do too. I think that's fine. So far, I have not had anyone hurt themselves with a TENS unit. There may be something about the tactile stimulation that then changes afferent signaling to decrease pain, much the same way that a massage would. I have had probably 3 patients at this point that claimed that SCDs, sequential compression devices put on to prevent DVTs in the hospital, claimed that those cured them and made them feel 100 times better. Well, that's a pretty low cost. I mean, never investigated that. Pretty low cost, low risk of harm. But I think there's something to be said for tactile input, whether it's a TENS machine or SCD devices or a massage or a self-massage. Something that's not going to cost a lot and not going to hurt anybody. Emotional stress results in increased pain. And I know in my patient population, my patients recognize this and point it out to me. And so one of the things that we have to do as clinicians, we can't solve the daily hassles and personally relevant stressors of life, but we can talk with our patients and coach them through their own solving those problems. And definitely cognitive behavioral therapies, mindfulness therapies, and biofeedback can play a role in the non-pharmacologic management of pain. So we're going to touch briefly on dealing with musculoskeletal pains from joint hypermobility. Again, numbers from the Big POTS study, about 28% of the POTS patients report having some type of joint hypermobility diagnosis. So how do we deal with that? Or how do we help our patients deal with that? So physical therapy is something that I refer my patients for a lot. And the guidance that I give my physical therapists is focus on those exercises that are going to strengthen the muscles around the major joints and or specifically the joints that the patient is having problems with. So some of my patients have more hand problems than they do shoulder or hip problems. I'm going to ask the physical therapist, use the tools in your tool bag to help my patients strengthen muscles that are going to support the affected areas of the body. And at least my experience is my physical therapy colleagues are good at developing rehabilitation plans for my patients that make them better and not worse, which we talked, Dr. Raj talked about rowing in patients who have hip dislocation. That's not going to work really well. I think especially for patients with hand problems, referral to an occupational therapist can be very helpful, especially for judicious design of splints, including ring splints if there's a lot of finger dislocation. Similarly, if there are a lot of foot problems, referral to a podiatrist. And I talk to patients about if it hurts, don't do it. So So exercise, do what you like as long as you're moving your body, and then if it hurts, don't do it. So if you're going to do something like rowing that's going to dislocate your hips, that's not the exercise for you. So prevent injury. I think there is a role for splints. I at least have some level of concern that I don't know if it's founded in reality or not, but at least some level of concern that if you use some type of splint or assistive device all of the time, your body's then not going to be able to support that activity naturally. So I call it the exoskeleton reliance syndrome. So if I have a splint on my arm all of the time to keep my wrist immobile, well, the muscles in my forearm are going to atrophy, and I'm not going to be able to support my own wrist naturally. And then you see non-steroidal anti-inflammatory drugs here with a question mark. We really don't have evidence for their use in joint hypermobility syndromes, but I definitely have a lot of patients who benefit from infrequent NSAID use when their joint pains get bad. So we talked about side effects of medications. Circling back, there's a list there for your referrals. Let me just say one thing about the SNRIs, particularly Cymbalta, duloxetine, I find helpful for patients with chronic pain and dysautonomia. I do tend to warn my patients with bothersome palpitations that this may make your palpitations worse. I would say that the majority of patients don't experience that, but in addition to all of the other possible side effects of the SNRIs, that's one that I particularly am concerned about in my POTS population. And I have had that problem with a few patients. A bigger problem for me is getting patients off of the SNRIs. Even they can get down to low doses, but then kicking that last 10 to 20 milligrams. Often patients just feel awful, crabby, irritated when they try to come off of them. And that's not everyone. But if I am weaning patients off SNRIs, I do warn them about that. So we're holding questions, and thank you.